Okay. Yes. Okay. So we are talking about venous system here, and all of a sudden it became arterial system because embolism happened in the arterial system. So what are the connection between both of them? And make the deep vein thrombosis and pulmonary embolism difficult disorder? ما سمعت ترى شيء. So how what's wrong with the heart? Okay, so most of the time deep vein thrombosis, which originate in the lower limbs, and this lower limbs will bring the thrombus to the right atrium. Then this thrombus, it will go or will travel to the right ventricle. And the right ventricle usually pump the blood to which organ? To the pulmonary circulation through pulmonary trunk, yes. And this will make, so in the other word, the lung is not protected from deep vein thrombosis. The left side is protected from deep vein thrombosis? Yes, typically yes, but there are exceptions. What are the exceptions? If there is connection between the right and left system of the heart. And this best example you will تاخذوه إن شاء الله in genetics, which is arterial septal defect or patent or foramen ovale. So those, like بنسميها بالعربي ثقوب, and the thrombus can travel from the right to the left, and this thrombus will go to where? If going to the left side, the left ventricle will eject the thrombus to the aorta and to all the organs. That's why the deep vein thrombosis is very, very important clinically. And if it happens, there will be bad consequences. And why we make it very important clinically? Because it can be prevention after surgery. And in a pregnant lady, if she gave a birth, we encourage her to walk, not all the time in the bed, because immobilization is one of the risk factors of deep vein thrombosis. That's why the deep vein thrombosis is very, very important clinically and can be prevented. Okay. So we all know back from the pathophysiology, for the body to have thrombus, there will be 3 criteria, or what we call it Fairchild triad. And I'm sure you went through this back in the second year. So one is damage to vessel wall. And this happened in, for example, patient post-operative for knee surgery, for example. And venous stasis, and reflected clinically by immobilization. Patient is not mobilized. And hypercoagulable state, in particular, for example, in pregnant ladies, patient taking oral contraceptive, patient with connective tissue disorder in particular, and other hypercoagulable disorder. So those triads, if they are there, so there is high risk of venous thrombosis. We are talking about venous system now. Okay? So most of the pulmonary embolism, which in the lung, it's actually originated from the deep venous system. And in the legs we have 2 venous systems. We have superficial and we have deep. So if the thrombus in the superficial, less likely to go for the arterial system, but deep vein thrombosis is the most common scenario. But sometimes the patient will have, however, less than 30% of patients will have symptoms in their legs, but not all the patients. Remember, not all the patients will experience symptoms of DVT in the lower limbs. And those symptoms include pain in the lower limbs, edema, redness, and ulcers. Not all the patients will experience this symptoms. So maybe the patient will present immediately with pulmonary embolism, and he has, when we do investigation, we will find deep vein thrombosis, but the patient has no symptoms. And this is another challenge in the clinical practice. 20% of the calf vein thrombosis propagate above the popliteal fossa. This is the only small percentage. And 20% of lower extremity venous emboli begin in the proximal veins without prior calf involvement. So this means most of the deep vein thrombosis originate from the proximal vein in the thigh and above the knee. So as a medical student, as a clever physician, you have to go all the time with the risk factor. And this risk factor will help you to categorize the patient and help you to put the patient either he is in low risk or high risk. Low risk for the disorder and high risk for the disorder. So those risk factors for pulmonary embolism and DVT is age. Number one is the age. More elderly patients, so they will have more risk factors. Previous thrombosis, if the patient has history of pulmonary embolism, this also will make the patient high risk. Immobilization. And can you give me example of immobilization? Post-operative we said about it?
Lung fly.
Sorry? Bedridden. Another example, common scenario. I said here, I think long traveling can happen. Patient in the, for example, in the airplane for 8 hours, 12 hours. So this is example of immobilization. Post-operative major surgery, especially orthopedic surgery. Why orthopedic surgery? Exactly, because we have now two problems. We have immobilization plus possible injury to the venous system, because the surgeon is working there. Estrogen, especially oral contraceptive pills. And believe me, if the patient is taking oral contraceptive pills, she will be at high risk of thrombosis. So if the patient, in other words, just to keep it in your mind, if the patient, she is taking oral contraceptive pills and she has a thrombosis, so we can go back and give her oral contraceptive pills like after 1 month, 2 months?
No.
Okay or not okay?
Not
No, it will be absolute contraindication because this will make her at more risk to have arterial and venous system. Those disorders, we call it connective tissue disorder. And previous in the aortic lecture, we all the time we keep saying connective tissue disorder, connective tissue disorder, connective tissue disorder. Why? Because they are very well linked with cardiovascular complication and arterial and venous embolism, malignancy in particular. All patients, there is no exception, all patients with malignancy, they are high risk for venous thrombosis and arterial thrombosis. Nephrotic syndrome, you will go through this also maybe in clinical years. Inflammatory bowel disorder and myeloproliferative disorder, long distance air traveling. That's why in the air traveling, they will give you some instruction to move and to move your legs. This is the reason. And head, we keep it this for clinical years, which heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia, this is life-threatening disorder. So sometimes you need to treat the patient by giving them heparin. And heparin, we call it anticoagulant. It's like blood thinner. But this heparin will make the opposite, will make thrombosis. So if you give patient heparin, and there is evidence of thrombosis, don't be surprised, because this is one of the complications of heparin-induced thrombocytopenia. Added to this, nowadays with corona, what we can add? Coronavirus infection is very well linked with thrombosis. There is high risk of thrombosis. Other than corona itself, vaccines, there are reported cases of thrombosis. So all those are risk factors. You have to note in details. Why? Because when you experience the patient, inshallah, in 4th year or 5th year, you're going to ask him those clinical risk factors. Okay. So inherited risk factor, those are patients born with this disorder. There is some who want to ask us, yes?
Why is superficial venous thrombosis?
Why what?
Superficial venous thrombosis. It does not cause thrombosis.
Yes, this is a good question. Because in the anatomy, from the anatomy, your colleague is asking why superficial vein system is less likely to have thrombosis. And this is a very good question because superficial venous system is linked with the deep venous thrombosis with small venous system. And this small venous system will not carry the big thrombosis. And even there is a thrombus, it will be very tiny thrombus, so will not make any clinical problem. So inherited risk factor, those disorder also is very common. We call it factor 5, Leiden mutation. Those all, we call it inherited disorder. So if you saw one of the patients, they have, for example, protein C or protein S deficiency. Those patients, they are born for thrombosis. So if the patient is presented to the hospital with, for example, DVT, and he has no clinical risk factor like those, so we're going to examine him for those hidden or not clear inherited risk factors. For example, some patients, they will start to have protein C or S deficiency, and they are brought to thrombosis again and again, and we don't want that. So how the patient present to the hospital? So the patient will not present to you and say, Doctor, I have pulmonary embolism. So he will present with symptoms. So the patient coming to you in ER, for example, with dyspnea. Dyspnea means difficult breathing. So the patient, he will tell you, Doctor, I cannot breathe. Another very, very serious and very important chest pain. And we will go to an acute coronary syndrome lecture. One of the major differential diagnoses is pulmonary embolism. You have to keep it all the time in your mind. Because why? Because if you don't think about it, believe me, in clinical practice, you will forget it. So all the patients with chest pain, put the diagnosis of pulmonary embolism in between your eyes. Cough and hemoptysis, why? Anyone can think? Why pulmonary embolism will present with hemoptysis? Hemoptysis means coughing blood. Okay, so if the patient has pulmonary embolism, think about it. The thrombus will originate in the deep system and will travel to the right atrium, then to the right ventricle, then this thrombus will be ejected to the pulmonary circulation. So the pulmonary circulation will be blocked. So what will happen as a consequence for that? There will be sudden increase in the pressure inside the alveolar system. So it will get rupture and the patient will present with hemoptysis. And when we do examination for the patient, we will have the patient tachycardia. And this is the most common clinical presentation for pulmonary embolism in the ECG is tachycardia, and we call it sinus tachycardia. Why? Because the patient has pain, really bad pain. Tachycardia, tachypnea means too much breathing too much. And why he is breathing too much?
Because he can.
As a compensation for this blockage, the lungs will breathe too much to compensate this deoxygenation. Tachycardia, because the patient has pain, and we call it S4. When we go in clinical years, we'll teach you what are S1 and what are S2 and what are the S4. Those sounds, when you put the stethoscope on the patient's chest, you will hear normally S1 and S2, nothing else. S1 and S2, lub, dub, lub, dub. But patient with acute pulmonary embolism, you're going to hear another sound. And why is that? Because we call it left ventricular strain. Strain means too much pressure in the left ventricle. So there will be added sound. So this is the story of S4. Now with B2, we have S1, which is a component of mitral and tricuspid valve closure. We have B2, A2, which is a component of pulmonary and aortic valve closure. And when there is pulmonary embolism, there is sudden increase in pulmonary pressure circulation. So the pulmonary artery pressure will go up. So we will hear loud B2. So we'll hear loud and dub, which will be huge dub. Okay. And sometimes the patient you will have fever. Sorry. And this is the field complication. If the pulmonary assume is massive, massive means blockage of the main pulmonary trunk. So there will be sudden deoxygenation of the patient. So they will present with hypotension and shock. And unfortunately, some of them they will die. And look to the lower limbs. Don't concentrate in the chest and forget the problem down there, which are the legs. And there before, zaman, we used to do what we call it Homan signs, but we don't do this anymore because there is risk of thrombus travel. Yani we'll give the patient more thrombus if we move his calf. So just forget about it. Just this is hysterical sign. We don't do this anymore. So differential diagnosis, if you saw, for example, swollen feet of the patient, usually it is unilateral. So the swelling will be both legs or one leg? One leg. Why? Because مو معقول يكون عنده two disorders at the same time. So number one is DVT. Number one all the time is DVT. And during the clinical year, we'll take details how we will examine a suspected case of DVT. Baker cyst, this is very common, and it's like a cyst at the back of the knee, and it can get ruptured, and the patient will come to you with severe pain. This is very common in men. Cellulitis in particular, very common disorder. Cellulitis means infection of the skin. So the patient will present with pain, swelling, fever, everything. So we call it cellulitis. Gout, sometimes gout present like this. And if there is bilateral, okay, we can think about DVT, but there are other differential diagnoses like congestive heart failure, weak cardiac muscle. Congestive heart failure means weak cardiac muscle, nephrotic syndrome, liver failure, venous insufficiency, pregnancy in particular, pelvic masses, and vasodilator, especially patient taking nifedipine. So you have to be very smart physician and ask the patient about all those disorder and medication. Clear the differential diagnosis? Differential diagnosis means when you're going to see your patient, think about other disorder, not only one disorder. So we talk about oxygenation and deoxygenation. Okay? So how we examine those terminology in clinical wise. So we call it arterial blood gases. Any one of you saw a patient with how we can do arterial blood gases? So we call it arterial because it's from the artery. Immediately we took it from the artery. And we examine the blood gases. And what are those blood gases? We go through it. So we put a needle in the patient artery immediately, either it is radial artery or ulnar artery or even any other artery, and we're going to take a sample. It is not a venous, it is arterial, because in the venous there will be already deoxygenation of blood. So that the diagnosis will be not accurate. But we'll go and take arterial. Okay. And also in the lab wise, something we call it D-dimer. And D-dimer is very helpful during ER presentation of the patient. And what is D-dimer? It is a D-dimer. D-dimer is like a lab test used to exclude pulmonary embolism and DVT. What does that mean, exclude?
No.
Anyone?
No.
Yes. If it is negative, okay, we said this patient has unlikely to have pulmonary embolism and DVT. But if it is positive, will not help. If it is positive, it's not helpful. So we call it the test of exclusion. If it is negative, it is good. Okay, exclusion. But if it is positive, will not help. So if you said what is the D-dimer, it's like end products of multiple biochemical changes during in the patient body. We can't explain it clinically, but it is what we call it D-dimerism. So because of the patient, why we did ECG for this patient? She's coming with DVT and chest pain. So any patient with chest pain, immediately the ER nurse, or what we call it ER triage nurse, she will do for you ECG immediately. You did it. She will not wait for you. So there is patient with sinus tachycardia. Why? Because this patient has pain. This patient has pain. And there is another less likely presentation, which we call it S1. This is S wave. I hope you know the wave. This is the B wave. This is the R wave. And this is the S wave. So in pulmonary embolism in particular, we have not very common, but maybe specific for pulmonary embolism, which is S1. Usually there is no deep S wave like this. So we call it S1. S1 means deep S wave in B1. Normally there is no S1, no S wave like this, but this patient has deep S1. And Q3, this is the Q wave, this is the Q wave, very deep, which is the first line here, we call it Q wave. This is happening in pulmonary embolism. So we call it S1, Q3, and T3. This is not very specific. Some students, they think this is very specific for pulmonary embolism. No. The first and very common clinical presentation and ECG presentation for pulmonary embolism is just sinus tachycardia. So this is what we call it S1. Usually, if we're going to see normal ECG, there is no deep S wave like this, no deep Q wave like this, and no, the T wave, it should be positive like this one, but it is under or below the baseline. This is the baseline here, and T wave must be above the baseline, but in pulmonary embolism cases, it will be below the baseline. This can explain clinically by right ventricular strain. Strain in cardiology means sudden increase in right ventricular pressure. Why? Because the pulmonary artery is already blocked. So the pressure before the blocked system, it will be high. Okay. So I hope you got this. This is very difficult, but this comes with pulmonary embolism. So as we said, ECG or AKG, you can call it. There is S1, Q3, T3. And some students, I don't know why, not in Faisal University, also in other universities, they think this is very common. Believe me, this is not very common. And there is sinus tachycardia. And there is what we call it poor R wave progression, what we call it acute right ventricular dilatation and right ventricular strain, all the same terminology. And there is what we call it right axis deviation. And I think you're going to take this right axis deviation, left axis deviation in separate lecture. What does that mean? That means there is deep SN1 and AVL, and this is defined right axis deviation. What does that mean? That means there is problem in electricity inside the heart. At extent, those electricity is deviated. Deviated يعني change of direction. Normally, the electricity should go in this direction, but something deviate the electricity, so we call it right axis deviation. There we go. So any patient with acute chest pain will do chest X-ray. For example, you may have atelectasis. Atelectasis is a terminology used to describe sudden collapse of the pulmonary structure. For example, in right upper lobe, right lower lobe, middle lobe, so there will be obstruction and collapse. So the lung got collapsed like a balloon. A balloon got collapsed, exactly the same for what we call it atelectasis. And sometimes this is when you will take it in radiology lecture. We call it wedge shape infarct periphery. What does that mean? That means absence of the pulmonary parenchymal tissue in a specific place. So you're going to see no parenchymal tissue, only dark area. So this is like infarction of the pulmonary parenchymal tissue. Why? Anyone can think? There is no blood supply, so the lung will shrink or will get bigger? It will shrink, like a balloon, exactly. The lung is like a balloon, exactly. So it will shrink, and this will, the absence of the lung parenchymal tissue. And sometimes there is a pleural effusion. Pleural effusion terminology used to describe accumulation of a fluid outside the lung, between the lung and pleural cavity. So they call it pleural effusion. Is this inside the parenchymal tissue or outside?
Outside.
It is
Outside.
outside. So inside the lung tissue we call it pulmonary edema, and outside we call it pleural effusion. Now we come to the clinical point of view, how we can deal with the patient with pulmonary embolism. We need to assign pre-test probability. And what does that mean in simple words? You are going to hear this terminology again and again in cardiology. We call it pre-test probability. What does that mean? So this means, in simple words, collection of the risk factor. If you're going to collect more risk factor, that means the patient has high risk or high pre-test probability. That means he has high risk of incidence of arterial and venous system. But he has less risk factor, that means unlikely to have, but still we're going to think about it. So pre-test probability is like a triage system in your mind, in your physician, as a physician, in your mind you have this system, you can classify the patient. This patient is high risk, this patient is low risk, this patient is medium risk, this patient is very high risk. So we're going to put this in your mind. Because this is how you will work in the hospital. Unless you will take all the patients as a high risk, it will be a problem. So this is a clinical judgment. So clinical judgment, you will hear this terminology again and again. It's not only about the physician, he thinks this patient, yes, this patient from far away, this patient is high risk. No. You're going to take a history, do physical examination, and collect risk factor. If you're going to collect more risk factor, you will tell this patient high risk of arterial and venous system. If not, you cannot. So at the end, there is a structure. There is written criteria for pulmonary embolism classification as high risk or low risk. We call it Wells criteria. And also again in cardiology, you will hear this terminology again and again. In MI, they will have a criteria. In aortic dissection, in other disorder, you're going to have criteria again and again. So you don't need to memorize all those. Just think about it. It is more numbers of risk factor. If the patient has more risk factor, that means for sure this patient he will have high risk of. And this, when you're going to read it, you will find that this is a risk factor. For example, a cancer. So we said in the beginning, cancer is a risk factor, isn't it? Paralyzed, that means immobilization. So makes sense now. Bed rest, again immobilization. Localized tenderness, it is localized. So it is swelling. Difference between the right and left calf. So that means the calf got swelling, isn't it? And edema. So then you collect those points and put it in the numeric system so you can better deal with it. So if you suspect...
Sorry, I have a question. Can you come back to the previous slide? Why collateral superficial veins are risk factor even though...
Sorry?
Why the superficial vein, the collateral superficial vein?
Collaterals mean if the patient has previous, for example, previous venous insufficiency, so those collaterals will get bigger. So the thrombus will move from the superficial to the deep venous system easily, more easily. Okay? For example, why this is very common? Because there is what we call superficial venous thrombosis, and this is very, very common. We call it varicose vein. Maybe if you're going to see some patients, they will have varicose vein, and those varicose vein, they have this spontaneous thrombosis and closure. So if there is a big collateral, so this thrombus will move from superficial to the deep, then from the deep to the pulmonary circulation. So if we got high test probability, so the patient has a risk factor. So the patient, he will have risk factor. So what we're going to do for him, we'll send him immediately to diagnostic study. Okay? And the diagnostic study, what we call it CT of the pulmonary artery. So we're going to see the pulmonary circulation. So negative CT, we call it CT angiogram. What does that mean? That means we inject iodine material inside the patient's body, and this iodine material will go to the pulmonary circulation, then we'll take images by CT scan. So if they are normal, that means totally exclude pulmonary embolism. So this is we call it test, test of choice in highly suspected pulmonary embolism cases. Why? Because you cannot send all the patients with chest pain to pulmonary to CT scan. It is not a logic. So you need to classify the patient. If it is high risk, immediately send him to CT angiogram. Why? Because this is like, so we expose the patient to the iodine substance, and this iodine, maybe the patient will have allergy after that from iodine, and again it is radiation. So we don't want to expose the patient to those two risks unless he has really very good reason and high risk probability to have pulmonary embolism. So I'll give you a scenario now. Patient comes to you, she's pregnant, she's for example in 5 months or whatever, and she's coming to you with left calf pain, swelling, tenderness, she has chest pain. So is it safe to send her to CT scan?
No.
Pregnant?
No.
Pregnant safe or no?
No.
It's not safe. So what we're going to deal, how we can deal with this patient?
Echo maybe?
Okay, ultrasound we'll do in lower limbs. So it is negative, nothing, no thrombosis or no clear thrombosis. So what we will do FEQ scanning. And this test is very safe during pregnancy. Again, it is very safe during pregnancy and safe if the patient has iodine allergy. Some patients, when he receives iodine, they will have allergy. Again, this iodine is absolutely contraindicated if the patient has renal problem. For example, high renal function, we can't give him iodine because we're going to push the patient in renal failure. So what we will give him? FEQ scan. Why it is not ultrasound? Because ultrasound cannot solve the problem. Even there is a thrombus down there. So FEQ scan, the idea is very simple. We'll do 2 images, one in the perfusion and one at rest, and we're going to see the difference. If there is a difference in 2 images, that means this patient has what we call it mismatch. Mismatch means one image has perfusion and one image has no perfusion. So this patient, he's going to have what we call it pulmonary embolism. So this is an example, don't bother yourself, I put it here just to show you what are the FEQ scan. This is a scan, it will be like this. So we compare both slides. One test is normal, one test is abnormal, so we call it mismatch. So if we stuck there, we cannot use CT angio, we don't have, not FEQ scan, it's like a nuclear test, so it's not available everywhere. Here we have it in King Faisal Hospital, and Al Habib Hospital and Big Hospital we have it, but not all the hospitals they have FEQ scan. Especially they have no FEQ scan 24 hours because some patients will present at, for example, 2 a.m. in the morning, so we don't have this facility. So what we're going to do, we'll go and what we call it, we'll do CT angiogram, And as I mentioned, I discussed with you. So this is an example. Is this venous or arterial system?
Venus.
Why it is venous? The result?
Valve.
Valve. So this is a deep venous system will look like this. If there is collateral here connecting the deep venous with the superficial system, there will be thrombus traveling from superficial to the deep. So this thrombus will go travel to where? To the right atrium, then
Pulmonary.
right ventricle, then. So it go immediately to the pulmonary circulation, and they will have pulmonary embolism. So this is the fear complication. Thrombus originating here. Originating here, then this thrombus is traveling from the right atrium, right ventricle, and immediately in the pulmonary circulation, then it will get plugged. This, for example, this here and this here. So that's why the pulmonary embolism is very, very important. It's very life-threatening disorder, and this is an example of CT scan. CT will give patient iodine. So this is iodine. This the white material here is iodine, and it should be all the way like this, white. But this patient has blocked. This one is a thrombus. So if you ask your patient, if you're going to see this CT ahead of time, what do you think about this patient? He has risk factor or no risk factor? Maybe, for sure he has risk factor because there is big thrombus is sitting there, and this thrombus will prevent pulmonary circulation, and the patient he will have sudden deoxygenation, severe chest pain, and also might have mortality and morbidity. Exactly, there is right and left. That means this patient has massive, what we call it bilateral pulmonary embolism. So this patient likely will have more. So this is an example of normal pulmonary circulation, and there is a blocked pulmonary circulation. Don't bother yourself with this slide. They are very difficult, but at least you got a hint. This patient has, for sure, he has risk factor, he has a problem, he has post-operative. Patient, she is taking oral contraceptive. Patient with cancer and immobilization. So if we stuck, for example, we cannot send the patient to the CT scan because the patient has allergy, or the patient has, we cannot do a CT scan for any reason. We have no PQ scan. We have no pulmonary artery angiogram. So what we're going to do, we will do what we call it echocardiogram. And what is the relationship between echocardiogram and pulmonary embolism? Anyone can guess? Echocardiogram is ultrasound for the heart. Ultrasound for the heart. So what is the relationship between? Think about it. Okay, check the sound. Exactly. So all the problem here is in the right side of the heart. And the right side of the heart consists of the right atrium and the right ventricle. And if there is a big thrombus sitting there and obstructing the pulmonary artery, the right atria, the right ventricle, which is immediately connected to the pulmonary artery, will get what we call it acute right ventricular strain. Strain means high pressure, and sometimes this right ventricle will get immobilized. It's not moving anymore. So we call it McConnell sign. This is sign we see it in massive pulmonary embolism. So echocardiogram can diagnose pulmonary embolism, can diagnose, can show you the embolism, or just give you a hint? Yes, because there is another reason for increased pulmonary pressure circulation, but this is suggestive of pulmonary embolism if you have no other alternative method. This echocardiogram is very frequently used in patients in ICU. In ICU, why? Because they are ventilated, so we can't send them to the CT scan easily. So we can't give them some of them they have acute kidney injury, so we can't give him contrast. So the alternative test is echocardiogram. If it is suggestive, immediately we're going to recommend start treatment for pulmonary embolism. So this is McConnell sign. It's like this happened in the right ventricle. So it will be hyper, the base of the right ventricle, this is called the base, will contract and the apex is not contracted. So this is immediately, usually those walls will contract in systole and relax in diastole. Will contract in systole and relax in diastole. But in McConnell sign, because there is very high pressure, preventing right ventricle from contract, so the apex, this is the apex, this is the base, and this is the apex. Apex, why? Because this is the apex of the heart. So this is the apical part of the right ventricle. This is the only part will move. Why? Because it's far away from the pressure. But the side of the ventricle, which facing the pressure, will not contract. It will not work. So we call it McConnell sign. And sometimes, if we are lucky, unfortunately we are lucky, but the patient is not lucky, we're going to see the thrombus is sitting there in the echocardiogram. Why? Because in echocardiogram, we partially see the pulmonary artery. Not all the pulmonary artery, just part of it. So if we are lucky, when we do echocardiogram, we're going to see this thrombus is sitting there. So this is the pulmonary artery. This is the main pulmonary artery. MBA means main pulmonary artery. LBA means left pulmonary circulation or left pulmonary artery. And this thrombus is obstructing which artery? Right or left? Right. Usually there is flow here. The blood is going smoothly there, but the blood going from the main pulmonary artery and blocked, totally blocked. So you think this patient is roaming around and he's taking his coffee, or he's very sick?
No, very sick.
He's very, very sick. Maybe he's in ICU. Okay. So the treatment of pulmonary embolism, the idea here, we cannot get rid of this thrombus easily. So we will go and recommend anticoagulation. Anticoagulation is very, very important in cases of thrombosis, either it is pulmonary embolism or DVT or what. But we have a problem. If the patient, for example, he has bleeding disorder, for example, patient has low platelet, very low platelet, and we give him heparin and he is bleeding now. So what we're going to do? Stop it. We have to stop it, of course, but the patient will have more thrombus now. So we put what we call it IPC filter. IPC filter, like a filter, we put it in the down there in the aorta or in the femoral artery, just to block any new thrombus coming out from the deep venous system.
What is the function if you put it in the aorta? Why do you do it?
It's like a filter, just, yes, it will, sorry, not in the aorta, in the inferior vena cava. So thank you for that. So we put it in the inferior vena cava just to prevent further and more thrombosis coming down from the deep venous system. So if you're going to start, in any case, you're going to start heparin, you need to ask or put in your mind if the patient has history of heparin-induced thrombocytopenia. Why this is important in particular? Because it's a killing disorder. So the patient will have thrombosis again and again, again and again, and again and again. So if the patient has heparin-induced thrombocytopenia, he is labeled as heparin-induced thrombocytopenia. We are good enough, or we are stuck there? Not really, because we have alternative. We call it direct thrombin inhibitor. This is another medication, another class of medication. I hope you will go through this in pharmacology lecture. So this is not heparin. This is another classes of anticoagulant, not like heparin, and it works immediately by blocking the factor of anticoagulation. So this one will block thrombin immediately. So it's not heparin, this is another medication. So assess need for hospitalization if the patient really need to be hospitalized in the hospital, or just give him anticoagulation and he's going home. If the patient has extensive DVT, increased risk of bleeding, limited cardio respiratory reserve, that means patient he has deoxygenation, poor compliance, and renal insufficiency or uncompliance to the patient, he cannot take low molecular weight heparin. So if those items are there, you need to admit the patient to the hospital. This is the idea. Now you have a case of DVT, for example. All cases of DVT should be admitted to the hospital? Not all of them. If they are good, they are well educated, so give them anticoagulation and they can go home. But if they are not, they have a problem, they have deoxygenation, or they have extensive DVT, yes, we need to admit them to the hospital. So we need to administer, there are two types of heparin, they call them low molecular weight heparin and unfractionated heparin. Unfractionated heparin, it has to be given IV or subcut. Low molecular weight heparin like enoxaparin, we give it subcutaneously. The goal to increase the coagulation system inside the body, so the goal is 1.5 to 2 times. That means the INR will be high. The INR normally, all the patient, everyone here, the INR for him is like 1. Okay, but we need to increase the INR or BTT because the patient he will have what's called blood thinner. So the idea here to prevent more thrombosis. The idea here to prevent more thrombosis, not to deal with the previous thrombus, because the previous thrombus is already there. So if the patient INR is more than 2, you can discharge him no problem, and we start what we call it coumadin or warfarin, and this medication used to make the blood more thinner, so they call it a blood thinner, and it is vitamin K antagonist. So the duration is very, very, very important, very, very important. 3 to 6 months in patient with indefinite treatment. Sometimes we'll give them treatment up to 6 months, and sometimes indefinite. Indefinite means lifelong. Okay? And if he has more than one spontaneous event, if the patient comes to you today with DVT, and after 3 months he has again DVT. So this patient, he must have the anticoagulation for life. One episode of spontaneous life-threatening event, like massive pulmonary embolism, patient comes with deoxygenation and shock hypotension, and phospholipid syndrome, those patients you have to deal with them very carefully. Connective tissue disorder and malignancy in particular. Genetic disorder, also we need to give them definite treatment. Protein C and S deficiency, and advanced cancer. If the patient has cancer, CA means cancer, so they need to give them anticoagulation for life. So what are the, sometimes you're stuck there. You need to give him anticoagulation, but you have contraindication. Contraindication means you cannot give him this medication. For example, patient coming with thrombus, but he has upper GI bleeding. He's bleeding from his mouth. So we cannot give him, unfortunately. And if the platelet is low, more than 20,000, and if the patient is post-operative, for example, neurosurgery, he has his surgery in his skull, then he has thrombosis. So we cannot give him. Why? Because there will be risk of bleeding. And there are absolute means never give him, never. But a relative, you can give him with caution, okay? So like mild and moderate bleeding problem, thrombocytopenia, brain mets, major abdominal surgery within 2 days, and other severe hypotension, endocarditis mean infection of the cardiac muscle, and GI and genitourinary bleeding within 14 days. So still you can give those patients relative, but you have to make your judgment. Brain mets, for example, patient has cancer and there is metastasis. There is more cells or metastasis from the primary disorder to the brain. So they call it brain metastasis or brain metastasis. So what we call inferior vena cava filter, sometimes use it because we stop. The patient is bleeding, the patient we cannot give him heparin, so only we'll put a filter for him just to prevent, not to treat the thrombus, just to prevent more and more thrombosis. And thank you. So, yes, any questions?
Yes.